everyone. Happy afternoon, a very good afternoon. I hope and I believe all of you are doing well. Quick nod whether the audio visual is all good. Amazing. That's great. Thank you so much. So, welcome to this YouTube live session, which is episode 58 in NF100. What is NF100? NF100 is the NEET PG FMGE Top100 topics, basically. So, we have reached to episode 58. Yesterday, we had episode 57, where we discussed the Darrow unit diagram, right? In the yesterday's session, we discussed the Darrow unit, and here we are discussing diabetes mellitus drugs. So we are going to learn some quick tricks on how to remember the drugs in diabetes mellitus, a very, very important topic from pharmacology. Before that, let me just update you about the All India mock test, which is coming up on 17th of April at 9 a.m., which has the All India prediction feature as well. So based on your performance, what rank you can expect in the upcoming exam is what we are going to work on in this mock test. And when you are enrolling for the same, you can use the code Dr. Nikita, and please do appear for this mock test so that you get to see, various types of questions from multiple platforms. We have also launched Unacademy Lite. Lite is basically the test series subscription. It's only the test series, which is the questions that you will be getting subject-wise, system-wise, and even the full length. Plus, you will get the previous year question papers. We are also launching for MBBS Prof Fund, the students who are entering into MBBS and starting with the new curriculum. So the new batch is starting from April 20, and this will help you crack the upcoming next as well. Auto DPPs, that is the daily practice papers, is what is available to the Plus subscribers after the class, before the class. And these are the questions which are picked up by educators, and you will get to practice that and see your understanding of the concepts from that particular topic. We have launched the new batch today for FMG students also for 1 month revision. Starting April 30, and also for the NEET PG students, a 1 month revision batch is what we have started today. Plus, we have this unique doubt clarification batch. Whatever difficulty you are facing in any particular subject, you can ask the respective educator. And whenever you are subscribing to the platform, you can use the code Dr. Nikita. That will give you additional 10% discount while you are subscribing. All right. Starting with the discussion of diabetes mellitus drugs. So we need to first understand, right, what do we need to do? What is our therapeutic goal in diabetes mellitus? So the therapeutic goal is basically to decrease the sugar levels, to decrease the glucose levels. Now, where all can we act to reduce this glucose basically is, one is the intestine. So whatever the patient is eating, if it is not absorbed, the glucose, the carbohydrates are not absorbed, that will decrease the glucose levels. Which is that drug which acts there? It is alpha glucosidase inhibitors, right? The enzyme glucosidase inhibition, so the absorption is not happening. Then from the intestine, it is absorbed into the blood, it goes. And from the blood, then comes the role of the kidney, into which the glomerular filtration, you have glucose, and all the glucose, maximum glucose, is reabsorbed from the PCT, the proximal tubule. So what can we do is, we can stop that reabsorption of the glucose in the PCT from the kidney, so that the glucose goes outside the body into the urine. So these drugs which act here on the kidney, that is your SGLT2 inhibitors. Remember, it's what a recent question as well. You have SGLT1, sodium glucose transporters, basically sodium and glucose, they go together. SGLT2 is what is present in the kidney. SGLT1, one is like Roman I, it is present in intestine. We have two kidneys, so SGLT2 is in the kidneys, intestine it is SGLT1. Okay, it is SGLT1. So these are your SGLT2. These drugs are your gliflozin. Gli, basically remember your glucose increase flow in the urine. So these are basically your gliflozins. The glucose increase flow into the urine. Okay, so like you have your canagliflozin, dapagliflozin. Remember, glucose increased flow into the urine. Slide is not clear, CF. For you, I think you just need to change the settings, the video quality, and I think that would be better. Okay. So one we have seen is basically your intestine में alpha glucosidase inhibitor, and the second one in the kidney, that is your gliflozins. The next that we have is glucose is coming from the liver, right? You have glycogenolysis, you have gluconeogenesis. These are your respective sources of glucose into the blood. So we can stop this as well, and this is done basically by Metformin. Okay, it is basically by Metformin. Maximum quality is 240. I think it's the settings that we need to change. I don't know why this is so. I don't know. Okay, I'll look into it. I'm sorry for that. Okay. So what were we talking about? It's basically the liver. So from the liver, the stores are inhibited to enter into the blood via metformin, and metformin also helps in tackling the resistance, right? The insulin resistance. Remember, we give it in PCOS as well, right? We give in PCOS also. The next that we have is your insulin resistance. The sensitivity is basically these drugs which act here are thiazolidinediones, the TZDs. How do they act? How do they reduce the resistance, increase the sensitivity? It is by acting on PPAR gamma. Okay, that's your PPAR gamma. That is your TZDs. So they act on adipocytes, they act on skeletal muscles. Basically, they increase the glucose uptake there. So they are decreasing the resistance, increasing the sensitivity. The next that we have is pancreas, right? So basically, to utilize the glucose, we need insulin. So whatever is helping in insulin release, we can use those drugs acting on the pancreas. So you have GLP-1 analogs, right? Your glucagon-like peptide. So you have your GLP-1 analogs, which will increase, and that is your exenatide. One group is exenatide, which is given subcutaneous. This GLP-1, which increases the insulin from the pancreas, it is degraded by the enzyme DPP-4. So you need DPP-4 inhibitors so that GLP is not metabolized and GLP increases the insulin. So we give DPP-4 inhibitors, which are basically your gliptins. Okay, gliptins, remember gliptins, GLIP, that is your GLP inhibitor. The GLP metabolism inhibitors, that is your gliptins. Okay, that's your gliptins. Exenatide, remember exenatide. Exe is like exocytosis. It does the exocytosis, basically the coming out of the insulin, that is promoted by exenatide. Okay. So look at this one, your DPP-4 and GLP. So when we are having the meal from the GI tract, there is secretion. It stimulates the secretion of GLP-1. This GLP-1 is degraded by DPP-4. It leads to inactive. So we need this DPP-4 inhibitors, which are basically gliptins. The GLP metabolism is inhibited by gliptins, right? Now look at this one. Okay, these are the various drugs that we have, that we already saw. You have alpha glucosidase inhibitors, alpha glucosidase intestine. So what is this drug? When do we need to use this drug? Before the meal or after the meal? Right, so when a person is having meal, you want the intestinal absorption to be stopped. So it is before the meal, like along with the meal is what is this drug needs to be taken, acarbose. Because the glucose is not getting absorbed from the intestine, right? Everything is going out. So what does it lead to? What is the side effect? What is the side effect? The side effect is basically your Flatulence, right? Flatulence. A lot of glucose, carbohydrates going out, that leads to flatulence. Also remember, you have colsavelum, the bile sequestrants, bile acid sequestrants have also been used in diabetes mellitus. Pramlintide, which is basically your amylin analog, this is the only drug which is used in both, that is type 1 also and type 2 diabetes mellitus. Type 1 and type 2, it helps in both. Bromocriptine has also been used in diabetes. What is bromocriptine? Dopamine antagonist or agonist? It is agonist. Why? Because it is used in your hyperprolactinemia, galactorrhea, right? Dopamine inhibits prolactin, so this is dopamine agonist. GLP-1 agonist, your incretins, increasing your insulin. DPP-4 inhibitors, inhibiting your GLP metabolism. Sulfonylureas, meglitinides. So these are the drugs which basically increase your insulin secretion. How do sulfonylureas act? How do sulfonylureas act in diabetes? They are basically your potassium channel blockers that increases the insulin release, right? It increases your insulin release. These drugs, they basically the second generation wale, they end in IDE, the insulin wale drugs, right? You have glipizide, right? Glipizide, meglitinide increases the insulin secretion. Next you have is basically your metformin. Metformin we said liver पे act करेगा, glucose नहीं आने देगा. So also acts on your insulin resistance. Then you have your insulins, TZDs which act via PPAR gamma, and you have SGLT2 which is glucose uric. What will be the side effect with this SGLT2? All the glucose going into the urine that promotes the bacterial growth. So that is your UTIs. Okay, UTIs would be the side effect with your SGLT2. Okay, SGLT2. Now look at this graph, which is your insulin K analogs. Give me a minute. Am I audible and visible, everyone? Okay. Yes. So in the insulin, which are the ultra fast acting insulin analogs, which are the ultra fast acting? Remember, it is lag. So basically, remember, lag have basically no lag. Okay. I don't know why the slide is not clear. I tried changing something, but still it is not working. All right. So ultra fast acting is your lag, which you have no lag basically. So you have your insulin Lispro, you have insulin Aspart, and you have glulysin, not Glargin. Remember Glargin. Glargin, when you write Glargin is large. It is large acting. That means it is long acting. So Lispro, Aspart, glulysin, Lis, these are the ones which are ultra fast. Glargin is your insulin analog, which you will see basically it is flat throughout. Okay, it is gonna have the initial, it is rising, and then it is flat throughout. Remember, it is the one which has acidic pH, and it should not be combined with other insulins. It is your peakless insulin. Okay, it's your peakless insulin, which is the longest acting insulin out of Detamir, Glargin, Degludec. Remember, it's your Degludec, which is the longest acting insulin. Okay, you can see that it's a flat line, the light pink color here. Degludec is the one which is longest acting. Which is the insulin which is given inhalational? Which insulin is given by inhalational route? Abhi nahi dete hai. But remember, inhalational is your Afreeza. Okay, Afreeza. Remember, like Afim जो हम लेते हैं, inhale करते हैं Afim, it is Afreeza. Okay, it is Afreeza. All right. Oh, what happened here? Okay. Now let's quickly have a look. Now we have seen the mechanism of action. Let's have a quick look at the very, very important. Is it working for everyone? Why am I not seeing that? All right. So where were we? We are here. Finally, something has worked and now it is all clear. You guys can increase the video quality as well if you want. ठीक है? Insulin. ठीक है? Insulin पे वापस जाते हैं. Let's revise this insulin. See, in the insulin, the one which are ultra fast acting is your lag. Lag has no lag. Remember, they act like super quick. They are ultra fast acting. Lag stands for your insulin lispro, aspart, and glulysin. It's not Glargin. Remember, Glargin is large. It is large acting. That is long acting. Also remember, for Glargin, it is acidic pH, so it should not be mixed with other insulin, and it is called as peakless insulin. It's long acting without a peak. Which is the longest acting insulin? It is your degludec. Which insulin is given via inhalational route? It is Afrezza, given like your Afrezza given as inhalational, afim ke jaise. ठीक है? Now let's go to this one, the side effects of the drugs. Okay. Vitamin B12 deficiency is a side effect seen with which oral hypoglycemic drug? Absolutely right. Remember, it is basically your vitamin B12 is like methylcobalamin. So remember, methylcobalamin, that is your metformin. Remember, it is metformin which causes your vitamin B12 deficiency, but it's not seen like immediately after you give metformin. Okay, this side effect takes some time. What is, if you remember, in one of the recent KBMDs we had discussed, a patient of diabetes needs to be started on metformin. What is the test that you should be doing? What is the test that you should be doing before giving metformin? It can cause lactic acidosis, right? So before giving, you will not do the ABGs. It is a side effect seen. Lactic acidosis risk is increased, especially if the patient has renal failure. So it is important to check serum creatinine, right? Serum creatinine. I hope every one of you remember that. MI, myocardial infarct, is a side effect seen with which drug? Which drug causes MI? MI, maximum heartbreaks, MI happening on the Valentine's Day, the Rose Day. So remember, it is your rosiglitazone. That's your thiazolidinedione. Rosiglitazone, maximum heartbreaks. Fluid retention, it is the same. So MI or fluid retention, it is with your rosiglitazone, thiazolidinediones basically. Pancreatitis, medullary thyroid cancer. Pancreas पे एक्ट करने वाला कौन सा है? Which is increasing the exocytosis, the excretion of the insulin from the pancreas. That is exenatide. Okay, that is exenatide. And similarly, exenatide also causes it has a risk of medullary thyroid cancer, right? Medullary thyroid cancer is seen with exenatide. Lactic acidosis, we just now said it is metformin, though the risk is more with fenformin, the risk is more. Disulfiram reaction, cholestatic jaundice, increased ADH, the anti-diuretic hormone, the C and D wale side effects, cholestatic jaundice, disulfiram reaction, ADH, all this are the side effects seen with C wala drug, which is chloropropamide. Okay, this is seen with chloropropamide. Your first generation IDE increases the insulin, sulfonylurea. Okay, that's sulfonylurea. Then you have nasopharyngitis. Nasopharyngitis, remember PP, that's your DPP4 inhibitors, which are basically gliptins, inhibiting the GLP analog ka metabolism. DPP4 is your nasopharyngitis. Next one, flatulence, diarrhea, abdominal cramps acting on the intestinal alpha glucosidase. It is acarbose. Remember, acarbose, A matlab nahi, carbo matlab carbohydrate, stopping the carbohydrate absorption from the intestine. UTI, urine flow, is your gliflozins. That is basically your SGLT2 inhibitors, right? That's your SGLT2 inhibitors. Urinary bladder carcinoma. Urinary bladder, passing the urine is like someone peeing. P is your P, that is your pioglitazone. Pioglitazone is your urinary bladder carcinoma. So, okay, all of these are very, very important. B12 deficiency, metformin. Lactic acidosis, metformin. MI, rosiglitazone, fluid retention, TZDs. Pancreatitis, exenatide. Medullary thyroid cancer, exenatide. Disulfiram, cholestatic jaundice, ADH, chloropropamide, nasopharyngitis, DPP4 inhibitors, flatulence, acarbose, UTI, gliflozins, and urinary bladder carcinoma is your pioglitazone. Okay, pioglitazone. Next one, tell me some quick points here. What is the only oral agent used in diabetes that has been shown to reduce the macrovascular events in type 2 diabetes mellitus? Which is the only oral agent that has been shown to reduce the macrovascular events in type 2 diabetes mellitus? It is metformin. Okay, remember it's your metformin which decreases the macrovascular events, which is taken in first part of the meal. Along with the meal, we said, because you want to stop the intestinal absorption, that is acarbose. Okay, that is acarbose. Insulin Glargin, is it short acting? Is it long acting? Is it short acting? Is it long acting? Glargin is large. So remember, large, that means it is long acting, acidic pH, not to be mixed with anything else, right? It's a peakless insulin. Which insulin is given IV? The rest of them, they are given subcutaneous. Inhalational is Afrezza. Which is the only insulin given IV? It is your regular insulin. So that's your drug of choice in diabetic ketoacidosis, right? To prevent your ketones formation, you need to give insulin IV. That is your regular insulin, which is given IV. Bromocriptine is used in treatment of diabetes mellitus. True or false? It's a true statement, right? We said it's a D2 agonist. We saw in the new drugs, Colcevelum, bromocriptine are used. Which is inhalational insulin? It is Afrezza, taken like a feme, that is your inhalation, that is Afrezza. Okay. Next, very, very important, a recently asked question. Only gliptin safe in renal failure. Which is the only gliptin which is safe in renal failure? Gliptin, sitagliptin, linagliptin, absolutely right. Remember, it is your linagliptin which is safe. So remember, linagliptin is like liver wala. It is not the kidney wala. So you can give in the renal failure. So that is how I remember. Linagliptin is liver wala. It's not the kidney wala. Metformin is safe in renal failure. True or false? Absolutely false. It increases renal failure, increases the risk of lactic acidosis. We need to test serum creatinine before giving metformin. Okay. SGLT2 inhibitors are given in both type 1 and type 2 diabetes mellitus. Is this true or is this false? SGLT2 inhibitors are given in both type 1 and type 2 diabetes mellitus. True or false? This is a false statement. Why is this a false statement? We give only in type 2 diabetes, we do not give in type 1 diabetes. Why? Because SGLT2 inhibitors, they are excreting your glucose in the urine. So the blood glucose levels will come normal. So a type 1 diabetic patient in whom insulin is very important, he will stop taking insulin, he will miss the doses of insulin. Decrease insulin will promote your ketone bodies, that will lead to your diabetic ketoacidosis, right? Because the decreased glucose, so the patient will not take insulin. So it's only in your type 2, not in your type 1. Remember, your DPP4 inhibitors are given orally. GLP-1 analogs, that is exenatide, that is given subcutaneous. What are the side effects we saw with exenatide? Pancreatitis, medullary thyroid cancer. DPP4, we saw PP, nasopharyngitis. Why is zinc added to insulin? Why do we add zinc to insulin? Basically to increase the duration of action. When you add zinc to insulin, the crystals, they get deposited in the skin, and from there the insulin is released for a longer time. So to increase the duration of action. What is lente insulin a combination of? How much crystalline, how much amorphous? How much crystalline, how much amorphous? Very good. Cracked NEET PG 22, absolutely right. It is 70 and 30. But remember, 30 is A, 70 is C. A comes first. Number 30, number 70, A comes first, C comes next. 30 A, 70 C. 30 amorphous, 70 crystalline. 30 amorphous, 70 crystalline. SGLT1 and 2 inhibitor, which is a drug which is both SGLT1 and 2 inhibitor. Something is wrong with my pen tablet also today. Which is the drug which is both SGLT1 and SGLT2 inhibitor both? It is your sotagliflozin, right? SGLT wala, your gliflozin. Remember, it's your sota. It is your sota. So you can remember this as it is your SGLT, O for 1, T for 2, A for antagonist. So it's both 1 and 2. Sota. It's 1 and 2 both. Remember, it's your sota, which is both. Okay. Next one. What is the antidote for beta blocker poisoning? What is the antidote for beta blocker poisoning? How will a patient of beta blocker poisoning present? Beta blocker, the heart will be depressed. Beta 1 is present in the heart, right? The heart will be depressed. You want to increase the cardiac contractility. What increases the cardiac contractility? It's your cyclic AMP, right? That is why we use your phosphodiesterase inhibitors in heart failure. You have inodilators increasing the cyclic AMP, they are inotropic. So you want to increase the cyclic AMP, give a drug which will increase the cyclic AMP without acting on beta receptors. That is glucagon. Very, very important. So glucagon is the antidote for beta blocker poisoning. Why? Because it increases the cyclic AMP without acting on the beta receptors. Beta receptors, last NEET PG question, they act via GS. Right, the hormone second messenger is cyclic AMP. They increase the cyclic AMP, increase the contractility. All right. Insulin is used in treatment of hypokalemia. Is this true or is this false? Insulin is used in treatment of hypokalemia. True or false? This is a false statement. Why? Because insulin, remember, takes the potassium in. Remember, insulin is in. It takes the potassium into the cells. So it is used in hyperkalemia. It is used in the treatment of hyperkalemia because it's taking the potassium inside. So decreasing the potassium levels. Okay, decreasing the potassium levels. What do you use in hyperkalemia if there are ECG changes also? The first thing is to stabilize, right? The first thing is to stabilize the heart, calcium gluconate. Then you can give insulin, and then you can give, along with insulin, what else can we give? Salbutamol also can be used, okay? Longest acting insulin, it's your degludec, right? It's your degludec, which is the longest acting. What will you give in a diabetic patient who is obese? Diabetic patient who's obese, that means you do not want the weight gain. It is metformin. Okay, it's your metformin because it does not increase your insulin release. Okay, it does not increase your insulin release. Diabetic patient, thin patient, you want to increase the weight. In that cases, you can give sulfonylureas, which increase the insulin. Insulin is anabolic. There will be weight gain. Rosiglitazone and pioglitazone, that's basically your thiazolidinediones. They require your LFT monitoring. They are hepatotoxic, right? So you need LFT monitoring. Which is the GLP analog which is approved for obesity? Which is the GLP analog which is approved for obesity? Your GLP analogs, like your glutides. Which is the one which is approved for obesity? Absolutely right. That is your liraglutide. I think I'll write here itself. Yes, that one is your liraglutide. Okay, that is your liraglutide, which is also approved for obesity. Why? You can remember this as liraglutide makes a patient lean. Okay, liraglutide makes a patient lean, that is thin. So it is approved for obesity also. Which is the only GLP analog which is given orally? We said that GLP analogs are given subcutaneous. Which are the ones which are given orally? Which is the only GLP analog which is given orally? It is semaglutide. Okay, that is your semaglutide which is given orally. Okay, it is your semaglutide which is given orally. Remember, semaglutide is in its sema, that is oral. वो इंजेक्शन में नहीं जाएगा, वो सिर्फ orally जाएगा. Only drug for both diabetes type 1 and type 2, that is your pramlintide. Okay, that one is your pramlintide, your amylin analog which is given in both type 1 and type 2. Okay, remember that's the only drug which is given in both. Okay, that's the only one which is given in both. So yes, I think that was about our drugs and diabetes mellitus. We've tried to cover everything possible, like the questions that have been asked and can be asked in your diabetes mellitus drugs. Remember, your thiazolidinediones are your PPAR gamma, not your PPAR alpha. Alpha is your fibrates, your hypolipidemic drugs. It is your lipid wala, that is your fibrates, that is your alpha. Okay, for lipid it is your alpha. Okay. So that was about the today's session, the NF100 episode 58. We have the plus class today. Right, we have the plus class today at 9 p.m. 9 p.m. to 11 p.m. The next class of radiology MCQs discussion is what we will be having. It's a radiology revision course going on. This is only for the subscribers. We have our next class. Tomorrow. That is a KBMD that we would be having. Tomorrow KBMD, because we have the plus class tomorrow at 11 to 1 p.m. We have the plus class which is scheduled. So we will have a KBMD at around 3 p.m. tomorrow. Okay, so KBMD would be at 3 p.m. rather than 12 p.m. tomorrow. All right. So 11 to 1 is the plus class. And then at 3 p.m. we will have the KBMD, which is your fast 5 clinical MCQs is what we would be having tomorrow at 3. All right. Okay. Thank you so much, everyone. And goodbye. Take care. Keep studying, keep revising, and keep